ulcer. Below you can see a wet HSV blepharokeratoconjunctivitis, which is a very vicious ulcer. Why should you know the difference? Because for the staph, the treatment is with steroid, and if you do that for HSV, I don't have to tell you what happens. So here the treatment is with dedicated antiviral therapy. So when you have an ulcer like this with a base like this way, how do you know whether it is infected or immune? Some pointers can help you. The middle picture, you see a Pseudomonas corneal ulcer. A lot of infiltration has happened, and just now the cornea is starting to melt. By contrast, on the top picture on the right, you can see a lot of melting happening in the murines, whereas there is hardly any infiltrate. So more of infiltration is infective, likely to be infective, and more of melting with less infiltration is likely to be immune, and that can be a pointer in differentiating. Also, when the disease is bilateral, when there are multiple lesions, when there are old telltale marks, these also point to you a relatively immune nature of the disease. Many times an ulcer doesn't heal because you've not dealt with the triggers. Here the patient is going on using NSAID. There is no infiltration, but still the cornea is melting. And here, unless and until you address the lid closure, you can see that the festering of the corneal ulcer is not going to resolve. The eye is not closing completely, so we need to take our minds and eyes away from the slit lamp once in a while. And here you see the treatment has made the cure worse. The bedside tarsorrhaphy that has done, the bolster is poking, the suture is poking. So these are impediments to the healing of the corneal ulcer. And here the infection has come and gone by with HSV, but you see the dull cornea with the rounded edges with translucent base. This is neurotrophic keratitis. I don't have to tell you that you need to discontinue medication and use pros. We use in-office pros, contact lenses for the treatment, but then the buzz is about topical insulin as well. Sometimes the corneal ulcer doesn't heal because, well, it has healed already. So this is a limbo state of pseudocornea where you see the epithelialization, a scar beginning to form. So here you should not go on continuing treatment. So keep the disease at bay and keep glaucoma in control. This will become an adherent glaucoma. I put in some mimics, but I'm not going to go through for interest of time. Just this one case on top where the patient was referred to us after a tear with an infection. So now if you watch closely, based on LASIK, we know that the flap detaches from the bed, it undergoes necrosis. And because it was a young patient, there was outpouring of hypopyon as an inflammatory response. So all we did was to de-epithelize the flap, clean the bed, and put the flap back with suture and put topical steroid without a drop of antibiotic. You can see in the next picture that the healing has come about completely. So for anybody that's interested, we'll take these rest of the interesting cases outside the hall, and I thank you very much for the opportunity.
Is it a pointer? So, good morning. Before 2015, most of us were treating corneal ulcers. We just had to differentiate a fungal keratitis from a bacterial keratitis mostly, and then start the treatment. But in 2015, a paper was published from LVPI by Dr. Savitri, where they reported 13 patients who had been treated as fungal keratitis with not a very good outcome, and the fungus was identified as unidentified fungus. But later on, from the archive cultures, they isolated insidiosum, Pythium insidiosum. However, this was not the first report of Pythium insidiosum from the world. There have been reports from, mostly from Thailand, but from India it was the first thing, and so it landed up us with another new kid on the block that created a lot of confusion and bad news. The first bad news was that Pythium clinically resembles fungal keratitis, and even on microscopy, direct microscopy, the filaments of Pythium, which are sparsely septate or aseptate, they resemble some of the hyaline fungal filaments, especially of Fusarium. Culture is a much more difficult process at that time, and so that was the second bad news. The third bad news was that because Pythium lacks ergosterol, most of the antifungals do not work, and ultimately we came to know later on, much to our chagrin, that it responds to topical antibiotics. And a lot of treatment failure was reported because of that. So the bad news is that if you land up with a misdiagnosis, then you land up with a mistreatment, and mostly the outcome is poor. It has been reported in the past that you can differentiate fungal from bacterial keratitis based on clinical pattern. So we thought whether this could be replicated in Pythium. Now, some of the clinical features of Pythium have been reported before, like tentacles, which are very thick hyphae, or reticular pattern, which is a net-like pattern of hyphaes and infiltrate, or you have this pin-sized intrastromal dots. So these were lesions that have been attributed to Pythium. We also found that you can have a furrow at the peripheral edge of the ulcer and or a gutter, and we also saw that it can also present as a ring ulcer, or you can have an infiltrate that has a sign of a central clearing. So these were the signs that we thought would be useful to differentiate Pythium from fungal keratitis. And we all know about fungal keratitis, the classic signs like dry surface, hyphae edges, endoexudate, satellite lesions, pigmented plaques. So those are very classical of fungal. So we put all these signs together, the ones we thought were very good for Pythium, and we took out the sensitivity specificity. Now if you see that the sensitivity of most of these signs are not great, and their positive predictive value is also pretty less. And one main reason is because Pythium is not as common as fungi, and that's probably very good news. But if you see the specificity of all these signs are very high. So if they are present, they would probably indicate the presence of Pythium, and the ulcer can be diagnosed as Pythium, presumptive diagnosis. So we thought, because the sensitivity is low, how about making the whole system more robust by putting it into a score? So we went about by doing two scoring patterns. In one, we included dry ulcer surface, because we found that in our univariate analysis data that I'm not shown here, there was a lot of Pythium ulcers where the surface was very dry, like we have in fungal. But clinically, classically, we have always attributed a dry surface to fungi. So we separated in another score, we separated the dry eye from that. And when we plotted a AUC curve, both the curves had a very, ROC curves, both of the scores had a very good AUC If you see the AUC 0.889 and 0.896, there's hardly any difference between the two. So if you have, and here if you can see, if you have one score, the sensitivity is very high, but you can see this specificity, that is false positive rates are very low. If you have one sign, the false positive rate will be around 11.6%. If you have two, it will be around 1.4%. And statistically, if you have three, you probably won't get three in a patient, but then you probably won't need a microbiologist to make a diagnosis. That is statistically. So these are the two scores that we had. So let us see if these scores are actually useful or it's just a statistical exercise. So in this patient, we had two of those signs positive, tentacles. You had these tentacles and you had these pinhead lesions or intrastromal dots. So you have a score of 2. And so the false positivity rate is 1.4%. So there's still a 1.4% chance that thinking it to be a Pythium in your clinic, you may actually be dealing with some other organism. So let us see what did you get in culture. So we got Pythium. So let us see in this second, this thing. Again, now here we had three, this thing. We had this tentacles, a reticular pattern, tentacles, reticular pattern, and then there was a furrow kind of this thing that we have been seeing very specific with Pythium. So three, probably we don't need to scrape this patient and just treat them with antibiotics. So let us see another patient, because we got culture there. Let us see another patient. So again, this patient had what we call tentacles, some kind of a reticular pattern. So 2 scores plus 2. So you have a false positive rate of 1.4%. So again, you see how good the scores are. So without this score, you probably don't need a microbiology. And then when you did the culture, we see that's fusarium. So you can't actually rule out microbiology from the whole picture. So then why are we talking about having a score and all these things? The thing is that we have different settings in our country regarding treatment of corneal ulcers. Suppose we all know that most of the comprehensive ophthalmologists or even a cornea specialist, if they don't have microbiology facility, then empirically everybody treats with what? They treat with antifungal, antibiotic, and if they are very, very diligent, they'll also add an antiviral so that nothing is missed out. So, but Pythium will not respond to anything like this. So, comprehensive ophthalmologists, by using the clinical score, increase the suspicion of it, they can refer it to a secondary center where there's microbiology facility and someone can distinguish filaments of Pythium from filaments from hyaline fungi, or the culture with blood agar gives 1 or 2 days results. And what about in a higher setting where there is microbiology facility? So if you are an ophthalmologist or cornea specialist in the clinic, you can warn the microbiology that we are suspecting Pythium, because even studies have shown that there's a lot of confusion with the filaments. So the microbiologist can be extra cautious and look at all the points where you identify the fungi. And sometimes if the microbiology report is ambiguous and you are also not getting a good response, and if you use the clinical score, maybe you will rescrape, reevaluate the patient, and then start the appropriate therapy. Thank you.
Thank you, Dr. Samrat. I invite Dr. Venkatesh Prashna for his next talk on fungal keratitis.
Thank you very much, and good morning. First of all, I would like to congratulate the moderators for starting the session on time. Great. How do I move this slide? Press the next one. This one. Thank you very much. So I don't have a conflict of interest. The first caveat is we don't know adequately about this condition, and we presume that we know a lot about this condition. The first thing which I have learned is I've now come to a conclusion that we need to give a lot of respect to this organism because it selectively causes serious problems, and it chooses its time, and it chooses its methods of destruction. So that's the fundamental thing I would like to address in this session. So there are instances. This is one case starting from top left, seemingly a big ulcer coming to a reasonably good finality, and this is a small ulcer which started off as a small ulcer ending up in perforation. And this is what I was just alluding to, that we need to be very, very careful about dealing with this organism. So what I thought was, in this 5 minutes which I'm going to speak, I'll be actually talking just on one aspect of the whole thing, which I think I have personally learned in this condition, is this slide. When you actually, I like this slide very much because we tend to treat everything like fungus. We tend to treat something like bacteria. The fundamental thing to understand is, in the same genera, the virulence factor is completely different. The virulence factor of Mahatma Gandhi to Adolf Hitler is completely different, and it doesn't make sense for us to treat everybody the same way. That is the fundamental concept I really want to address in today's session. I'll just give you some examples of this. So this is Fusarium on the left, and this is Aspergillus on the right, and at this point of time we tend to treat both of it in the same manner. The growth, the microscopic features, and the scanning electron microscopic images, completely different. It doesn't, it looks similar in certain identification factors, but when you allow them to grow as they would in the cornea, and that is the fundamental difference. If you allow them to grow in the cornea, they have a unique, distinct mechanism of how it causes a disease. And this is a work which we did with Pasteur Institute in Paris, because they were interested in Aspergillus flavus, Aspergillus fumigatus, because it causes a problem in the lungs. And we wanted to know why selectively Aspergillus flavus causes a disease in the cornea, while Aspergillus fumigatus causes a disease in the lung. And you can see there is a fundamental difference in the rodlet layer. Why is this important? Because this is what provokes the host immune mechanism to cause a disease. And so within Aspergillus, you can have a different surface thing which will actually induce the human immune mechanism to behave differently. We also know that there is definitely a difference between the clinical response to Aspergillus ulcers to Fusarium ulcers. Aspergillus ulcers are comparatively more, have a more poor prognosis as compared to Fusarium ulcers, and that is because of the differential response to natamycin, where Fusarium responds much better to natamycin. And the same thing was also reflected in the microbiology setup to know that there is a difference basically fundamentally between Fusarium and Aspergillus. But what was more interesting is this thing which I'm going to talk in the next 2 slides. 80% of the mud sequenced Fusarium isolates were Solani, but what we found out was when it is caused by Fusarium solani as opposed to other Fusarium, Fusarium solani is causing more of cornealopacity. It excites the human system much more than the other parts of Fusarium. So this is just the same mud sequences. And you know that once it's more pigmented, it's supposed to be more virulent. And here is the spectrum of Fusarium solani causing different pigmentations in whole this thing. So within the Fusarium, there are multitudes of acts of virulence there. Now that is one part. So we have multiple variations in the organisms between Aspergillus and Fusarium, within Aspergillus, within Fusarium. So that is the fundamental difference I want to sell across. What happens to the host response? So this is the thing which we published in 2019, where we said zinc alpha glycoprotein, which is an immune marker of the host immune response from the tears, there is a difference in the zinc alpha response, ZAG response between flavus infection and a Fusarium infection. We thought it could be a marker, but to be very frank, it doesn't work that simple. But the fundamental difference to understand is there is a difference in the immune response to a Fusarium versus an Aspergillus at the tier level, at the protein level as such. So these are my last 2 slides. What do I foresee something happening, especially in a fungal disease? In the retina, as most of us who started practice in the 80s would understand, it was all about light. It was all about photocoagulation. Then the fundamental shift from photocoagulation to drugs. So this is what is going to happen possibly in the surface surface aspects of fungal infection, where it's just going to be reverse of what is happening in the retina. We wouldn't have dreamt that lasers might not be used as much as what we used. But then this is what probably is going to happen with regard to the surface disease of the fungal. But the deeper disease, it's going to be a different ball game. And at this point of time, we are actually concentrating on killing the organism and trying to say that we are controlling the disease. But the future, the game will be at this place and not at just killing the fungus and thinking that we have conquered the disease. So the fundamental message I want to say is the fungi are not as simplistic as they seem in a KOH mount. Thank you very much for your patient hearing.
There is a surgical management which we should know about, which can help you to save an eye in difficult situations. So I'm talking about some nuances which you need to pick up in conjunctivoplasty. So this is an old procedure, Gunderson in 1958, that's why it is also known as Gunderson's flap technique. The one fundamental thing to remember is that the superficial conjunctiva, just like you do a pterygium, the superficial conjunctiva is the one which you need you don't need the subconjunctival tissue. The subconjunctival tenons, the subconjunctival connective tissue, you should separate. Your conjunctiva should be as thin as your conjunctival graft which you do for pterygium. So I don't believe in partial conjunctivoplasties or partial flaps. You do a total flap, and the indications are those with little visual potentials. I have had patients who had suicidal tendencies because of the pain and the suffering with no perception of light that they had. They wanted an evisceration or an enucleation, just remove the eye type of thing. So there, a conjunctivoplasty well done will relieve them of symptoms. Also, while waiting for optical procedures, like during the pandemic, we did a lot of conjunctivoplasties when we didn't have tissue available, and neuroparalytic non-responding corneal ulcers, some of those which lovely slides that we saw. So if they're not responding with whatever and you're waiting and you expect that they might perforate, you can cover it with the conjunctivoplasty. It gives you breathing space, a few months in which you can continue to treat, and then when you've got the definitive treatment, you can go in and do a keratoplasty later. Recently, for no PL patients with cosmetic blemishes, we've been doing a lot of tattooing at the same time since we acquired these tattoo guns, and tattoo ink is freely and cheaply available on Amazon. So we've been tattooing the surface. It's like doing an anterior stromal puncture and then covering it with the conjunctiva, and the cosmetic appearance also is much better than simple conjunctivoplasties. So the technique, I'll show it to you on a video. You scrape the epithelium off, then you tattoo with a tattoo gun and India black ink. You do a 360-degree peritomy around the limbus with a blade. Dissect the conjunctiva free from tenons. Again, I say this is something that we need to just remember. Excise the underlying tenons. So not only do you remove it from the tenons, lift it up, but chop off everything underneath, so that there's no, otherwise that fibrous tissue will go there and retract the flap. So if you don't want flap retraction, you need to chop off the tissue, and I'll show it to you on video, and make the conjunctiva as thin as possible. You might buttonhole while making it thin, doesn't matter, you can suture it with 8-O-polyglactin. Then I make 2 scleral partial thickness incisions at 4 and 8 o'clock, we'll see this on video, and pull the superior conjunctiva over the cornea and suture it to the scleral grooves. If too much tension, you can make relaxing incisions, but I've seldom needed to make relaxing incisions. Even when I've done it in post-trabeculectomy eyes where there is already scarring. I use 6-O vicryl sutures at 4 and 8 and 7 or 8-O vicryl in between, and take sutures close to each other.
This is a patient of bullous keratopathy following
I'm just removing some
graft
sutures
rejection.
from a failed graft.
Patient
Scrape the
complained of
epithelium
pain,
off.
redness, watering, and was also concerned about the white
You need a good assistant
cornea.
when you're doing this,
So
and
we
you need
did a
music
tattooing
of the
with
assistant's choice.
India
These two
black
things
ink
also are
available
things
from
to be remembered.
internet.
So we put the India
And
black
this is
ink
the
and we're
Gucci
using
Chinese
that gun, which is nothing except an
instrument
needle which keeps
which
poking
makes
in.
multiple
You
stromal
clean the surface,
punctures
make sure that
at
the
a predetermined
ink has
depth,
gone
and
into
the
the
motor
stroma.
moves at a
So you
predetermined
scrape
speed.
the top with the
So the
cotton
whole
bud as well.
process takes barely less than
And you
5
can
minutes to
repeat
do.
this, it takes
You
hardly
just
5
put a
minutes
drop
to
of the India black ink
do this procedure.
and then apply this,
Of course, this is
needle.
not mandatory.
scrape,
So I scrape
and
the top
with
and
a
found
cotton
that
swab
the
to
ink is
see that
already
the
there.
dye is still there, and apply
Then I
again and
proceed
again
with the
the
conjunctivoplasty.
needle. You may need to put one more drop, but just one drop otherwise is sufficient for these patients, and you get a very good black tattoo, which when you scrape on the top of the cornea also, you can see that the dye is still retained in the stroma. This beats the previous manual methods in time and in the consistency of the dye
Don't bother
penetration.
about the limbal stem
This
cells.
patient also underwent a
Patients in whom
Gunderson's
there is no
flap
visual potential.
because
If
though
you're
an
doing it
anterior
while
stromal
waiting
puncture
for a
can
cornea,
reduce
then you
the
preserve
symptoms
those
of the
limbal stem
patient,
cells.
in a patient who has got a complete total bullous keratopathy like this, the
360-degree
symptoms don't go
peritomy.
away unless you do
Now,
a
the assistant holds
Gunderson's
the
flap procedure. So since this
conjunctiva
patient
up,
has no visual
lifting
potential,
it towards the
we cut
sky
the
and lifting it away from the
conjunctiva
limbus.
close to the
And see
limbus,
what I'm doing?
and
I'm
then an
chopping off
assistant
the
pulls up the
subconjunctival tissue.
conjunctiva towards the ceiling
So it's not
and
necessary
a little
because
away from the limbus, while the surgeon
it's
cuts
important to chop it
the
See that you
subconjunctival
don't
tissue
chop off muscles.
using a blunt Westcott
and see that you
scissors.
don't go so deep as to
Take care not to
the
go too
orbital
deep
septum, because when you cut the orbital septum, again
inside,
you get
otherwise you will cut the
pseudotosis,
orbital
fat
septum,
will herniate.
and that will
So
produce
this is
a
important
bit
because
of
the
ptosis.
assistant might drop the
So
conjunctiva while you're
the
cutting,
assistant
and then
needs
you'll
to
get a
drop
buttonhole.
the
So you must be
conjunctiva
attentive, not
and
fall
pick it up
asleep.
in an adjoining
It's quite a
area
boring procedure
with
for
two
you.
plain forceps.
So it's important to go
While the
360.
surgeon
Why do we go
uses a
360?
limbs
Because
forceps
if
and a
there is too
Westcott
much scarring, I
scissors,
may take
cut
it
the
from
underlying
temporal to
tissue.
nasal or nasal to temporal.
This
So
process
90%
goes
of
on
the cases I
360
go from
degrees
above below.
all
So he's
around.
lifting it up,
You can see
then
this
he
being
drops
done.
it,
Of
lifts
course,
it at a different
care
size.
must be taken that the muscles are not cut. If you
So
need
this is
in
the
a
subconjunctival
beginners,
tissue which
you
I'm
can
chopping off.
identify the muscles by hooking them up, but later
Once
it's
you've
not
gone
necessary.
360 degrees around,
How
you
do we
it the second
identify the
time,
orbital
perhaps the
septum?
third
It's a
time. Every
whitish
time you do it,
tissue.
you'll find new
So when
tissue.
you pick up the tissue
will
and you
be
see some pearly white tissue, you stop and don't cut that, otherwise the orbital septum is breached. So
this
we
is the
go
second
once
time
around
I'm going and I'm
then
still
we go a
finding
second
tissue.
time around as well. The idea is that the conjunctiva should be almost translucent or transparent.
That's
that
the
thin
buttonhole
it
that
must
I've
be
created.
when all the
Yeah.
underlying tissue is removed. While doing
So
this,
it should
sometimes you
cover
get a
about
large
4/5
buttonhole
of
as
the
can be
cornea
seen
with
here.
the
There's no need to
speculum in
panic.
place. If it's a
You can
buttonhole, you
simply
just
close
suture
the
the
buttonhole
buttonhole
with
with
one
one
or
or
two
two
interrupted or
mattress
mattress sutures with 60 or 70 polyglactin
Not the end of the
and
world.
proceed. So when you
Then
pull
I
the
take
conjunctiva down
two
on the cornea with the
cuts,
speculum
one at 4
inside,
o'clock,
you should be able to cover roughly at least 3/5 to 4/5 of the cornea. Now you make with a Bart Parker 15 number blade, 2 cuts at 4 and 8 o'clock,
thick sutures
and
with
with
6
6
polyglactin.
polyglactin sutures, you take mattress sutures through the cuts and to the
Bring it down.
conjunctiva.
So there should be no
So that
tension.
these are
The
the
speculum
anchoring
should be
sutures
nicely
on
fully
both the
open
sides,
at that
4
time.
and 8 o'clock. So the first suture,
that you know
first
that the
needle
palpebral
goes through the
aperture will open
conjunctiva,
well. Otherwise
then
you
to the
don't want
sclera,
to
then to the
pseudotosis
sclera and then
patient
conjunctiva.
for
So
speculum.
once the two anchoring
Once you've
sutures
done
are
this,
taken,
almost 4/5
the
of the cornea
intervening
is
tissue
covered.
can be
The rest
sutured
can
to
be
each
done
other
with
fairly easily
7
and
or
without
8
any
microns.
tension. The suture
I
should be
prefer
close to
interrupted
each other,
sutures or
can
mattress
be
sutures
interrupted or
close to
mattress
each other.
sutures, and there should be no tension applied, no
fairly tight.
tension seen.
So
If the
this is
tension
the
is seen,
end
that
of
means
the
your dissection has not been thorough enough.
result is quite cosmetically appealing. So results are usually long lasting, can help save the eye from phthisis. Retraction, if it occurs, you can't repeat the procedure. Buttonholing is not a problem. You can have some small problems. If there is fading of the dye, you can re-tattoo as well. Post-op management is quite routine, and I urge you to just do these two things. One is chop enough conjunctiva, enough subconjunctival tissue, and take stay sutures at 4 and 8 o'clock. And I think you have one more surgery in your armamentarium which can help an eye from going into phthisis. Thank you.
Dr. Mascati. I would invite Dr. Chintan Malhotra for the next talk on corneal imaging in microbial keratitis and AI.
Can somebody help me with the connection, please? A very good morning to all. Completely par excellence. I will just be talking a little bit about the role of corneal imaging in microbial keratitis and the role of AI in that. So it's a cliche, but it's true that the cornea is the window to the eye. And I'd like to think of it that the corneal imaging is a window within that window. The main two techniques which are used are the AIOC and the in vivo confocal microscopy, the latter being more useful, as we'll see. So various patterns have been identified on AIOC for microbial keratitis. Just to share a few, for example, if we see hyperreflective material over the epithelium or endothelium, this is inflammatory plaques. Fibrin may be seen as a cobweb on the cornea or in the AC as well, and tissue destruction would be seen as stromal thinning. But as is obvious from these images, these patterns are not specific to any particular microorganism. So they are more suggestive of somewhat of a pathology rather than an etiology. But in some cases, retrocorneal plaques have been shown to be a pointer towards an etiology, although it's not useful in all cases. For example, in herpetic keratouveitis, it's said that there's a clear demarcation between the plaque and the posterior cornea, whereas in fungal keratitis, the plaque will have irregular borders. Coming to the other technique which is more useful, which is the in vivo confocal microscopy, and I like to call it the third eye, which helps us. So it provides us, especially with the laser scanning HRT3, it provides us with very fine resolution of as small as 1 to 2 micrometers. So this is a situation which we see all the time. It's clinically fungal, but sometimes its KOH is negative for hyphae, your culture doesn't grow all the time. And confocal microscopy, we see these crisscrossing interlocking structures, which in no doubt are hyphae, which are branching, bifurcating, and these are usually not seen in isolation, so that's important. Another case, this is a 25-year-old male with a dirty-looking epithelium and some stromal infiltration. Clinical examination, of course, is always important, as Dr. Radhika mentioned in the beginning, and we see that there are these linear structures at the periphery, which is probably suggestive of radial keratoneuritis. And you go in and you see classically on confocal microscopy, this is the oblique view where you see acanthamoeba cysts, which may be double-walled or they may not be double-walled depending on the image that we got. And these are usually 10 to 20 microns in diameter, but the size may vary and they may be very small as well as very large. Now, why IVCM in fungal and acanthamoeba keratitis and also another atypical keratitis? Because both can be difficult to culture. Detection may take up to 2 weeks even in positive cultures, and organisms may be located deep in the corneal stroma, sometimes requiring a corneal biopsy. And IVCM tends to overcome these difficulties because it gives you an instant diagnosis or points you towards the instant diagnosis, and it can significantly shorten the diagnostic delay and improve the patient outcomes. Especially for acanthamoeba and fungal, the sensitivity and specificity both are quite high in the range of 90% or even greater, and it's even been shown in fungal keratitis to have a greater sensitivity than cultures. Another example, this is a 35-year-old lady referred as having a ring infiltrate on treatment with antifungals. A cornea person looking at it would think that it looks like a wreath-like pattern. You do a confocal microscopy and you see multiple short beaded filamentous structures which are thinner than fungal hyphae. And I would just like to draw your attention to how closely this pattern resembles what is seen on the these beaded filaments which are seen on the gram stain, and this was a case of nocardia. And so the treatment is with topical amikacin, and the patient responds beautifully because amikacin is the drug of choice in this case. Microsporidial keratoconjunctivitis can be seen as well. These appear as bright ovoid bodies resembling the spores seen on KOH and calcofluor white, and these are much smaller than the acanthamoeba cysts that we usually see. So clinical situations where IVCM has an edge is deep lesions not accessible to sampling, unresponsive and atypical keratitis, and culture and PCR negative keratitis. For any unusual looking case, if we have confocal microscopy, that's usually my first go-to investigation even before we send the patient for scrapings. And coming to the last part of my talk, which is artificial intelligence in microbial keratitis, I must admit I have no personal experience with this, but it's been interesting going through the literature. And we have Dr. Prajna and Dr. Radhika here who have great publications on this. So as I understand it, there are different levels of artificial intelligence, and the one which is most useful is deep learning. Now, what does it basically mean? That given inputs and their desired outputs as examples, the computers learn to solve a task for itself. For example, if we tell the algorithm that a car is supposed to have these features, it has 4 wheels, it has a steering wheel, it's smaller in size than a truck, which also would have the same features, then it extracts those features, classifies it, and it will tell you, give you the output, is this a car or is this not a car? So AI in microbial keratitis or anywhere, as I understand it again, would be a form of pattern recognition. And it identifies patterns in images of the eye that are unrecognized by, let's say, the less trained human eye or the brain. For example, a paramedic screening patients in the remote area. You could have white lesions. Is this a keratitis or an opacity? If keratitis, is it bacterial, fungal, or viral? So most of the AI is based on either slit lamp or external photography, or it is based on confocal microscopy. So this is an example partly from the Arvind group as well, where they've compared the P1 and P2 are the images which were seen by the physicians, and they took 4 features, the pathological features like stromal infiltrates, hypopion, WBC edema, and non-pathological features like the light reflex and limbus, and then they classified it as having the patient having keratitis or not. And this was compared to the AI algorithm, the neural network, the SLITNet, and it was seen that the images generated by the artificial intelligence had a fairly good match with what was seen by the clinicians. Another article where the diagnosis of HSV in necrotizing keratitis was seen, and it would use the similar modalities, I guess. Important to know what is the sensitivity and specificity of these. So around 70% accuracy has been seen. Another study showed approximately the same results, that AI model achieved approximately 70% accuracy, and this was higher than non-cornea specialty ophthalmologists, but luckily our jobs, I think for the time being, are safe. It was lower than cornea specialists. And just the last slide, so there are studies, like I mentioned, on confocal microscopy-based studies, which have mostly been done for fungal keratitis and acanthamoeba. So again, those features, and for confocal micro-based studies, the specificity is higher than what it is for the others. So to conclude, corneal imaging is an important cornerstone in the management algorithm of microbial keratitis. Artificial intelligence, while at a relatively nascent stage currently, is likely to become more sophisticated and accurate, and AI thus will have an increasing role in preventing infectious keratitis-related blindness, especially in remote areas and resource-poor settings. Thank you very much.
Thank you, Dr. Chintan. I request Dr. Savitri Sharma to please come with her talk on ocular microbiology, the next frontier.
A very good morning to all of you. I thank AIOS for giving this opportunity, and I'll be talking about the next frontier in ocular microbiology. We know that clinical features, direct smear examination, and culture are the pillars of diagnosis of corneal infections, and I belong to this school. But in recent times, we have been moving away, or at least we have been hearing that we need to move away. Why is that? We are realizing the limitations of conventional in vitro culture methods. It's a low sensitivity and it takes time. And we also find that over time, in this publication we have shown that culture negatives are increasing. And new studies like using next generation sequencing, they show us that it's not only one organism or two organisms, there are multiple organisms present in an infection. So what do we do with this information that we are getting? We are moving towards that. The advantages are they're very highly sensitive methods and very, very specific as well. And they give you reliable confirmation of new organisms. They also confirm the presence of organisms which are difficult to culture. So these are the advantages that we may have. And the basic of this is all DNA of all organisms are similar. DNA is same. You can have different methods, and one of that is nucleic acid probes are available to identify. Now these are targeted. You need to know which organism you are looking for, and then you use the probe for that. PCR is also targeted. Usually you amplify the DNA and then identify that in a gel electrophoresis, and you can find the presence of the DNA. There are many modifications of this PCR. Multiplexing will just increase the number of targets. It will not be all, but some of them. And you can have nested PCR to increase the sensitivity, and I'll go through the others in next slides. DNA chip, we are very proud that in India, our first DNA chip for ocular infections was made by Exciton, and we had worked along with the RP center with them. They actually have a center in Bangalore, and you can send samples there. They use the technique of multiplex PCR with hybridization and give you the report within 24 to 48 hours. We all learned about real-time PCR during COVID. Whether you knew or not, everyone was talking about real-time PCR, and we know that it's a very, very sensitive method for diagnosis of viral infections. A lot of work is going on about DNA sequence. We are not stopping at finding DNA is present. We are looking at the parts of the DNA. What are the ATCG sequences in that part of the DNA that we are dealing with? And that's what is called DNA sequencing. Very beautiful methods, very quick methods are available to now find out the sequences, which to make it so simple, you just see 4 colors, A, T, C, G, it tells you, and you get alphabetical, you can see a whole long chain of alphabets of A, T, C, G, tells you what is the sequence of these bases in the DNA sample. And then there are software which will tell you which organism you are dealing with just using that sequence. There were many studies, actually 2008 itself from Aravind we had studies to show that PCR is more sensitive than culture, and we also showed that real-time PCR is more sensitive than uniplex PCR or targeted PCR. Sequencing helped us really to catch the pythium that we have been talking about. So it is used for identification of different species, and here is in a phylogenetic analysis you find that we were actually dealing with pythium, what we were not able to identify. And retrospectively we learned what is the smear looks like, what does the culture looks like, and also we learned the formation of zoospores, which we are extensively using for antibiotic susceptibility testing for the pythium. But we are not satisfied with that. We are now going to next generation sequencing. So what I meant by targeted is a short fragment of DNA, a particular type of DNA, whereas that is overcome in next generation sequencing. You look for any DNA that is present there. You will detect from human DNA to all other DNA that is present, and therefore it is unbiased and untargeted is what it is called. And it is very, very good for identification of unknown organisms in the sample. So this is a massive parallel sequencing that is done to capture large amount of genomic data, and it is less affected by the prior empiric therapy. DNA is not affected, and so that's one advantage. And people are now trying to make bedside setups or tests which can be done in the small laboratories to identify the organisms. There are various types again in this. To a certain extent, you can target just all bacteria or all fungal, and then there is another one which is called shotgun metagenome, which is just to identify any DNA present in the sample. So where are we going with this? There are big machines called Illumina. I was very lucky to just visit Kalyani, which is very close to Calcutta. I never knew there's such a beautiful institute we have, which actually does everything that can be done in genomics. It's a National Institute of Biomedical Genomics, and very, very wonderful. LV Prasad is having some collaborative study with them, and that's why we visited them. So they have everything that is mentioned here, Illumina, pyrosequencing, and but for diagnostically, we are actually more interested in nanopore techniques. They have that too. And not only that, I visited a place in Mumbai, IIT, where a company called Haystack Analytics, they are actually very close or almost have done for tuberculosis. They do NGS, it can be done in a small laboratory. This is a setup picture I have shown here. It's just a small setup here with a monitor there, and you can actually they put the sample, just treat the sample a little bit, put inside that, and you can get the report like this. I have shown here the report shows it's a pathogen, Escherichia coli, and it's got resistant genes. What genes are there in that which is causing the resistance, and you can get a report with all patient information. So they have come up to this stage. It's very, very successful for tuberculosis, and now they're working on urine infection, and we have now tied up with them for ocular infections. So we are moving very close to that. There are also studies and actually published now and in use in the US, a multiplex PCR with the hybridization technique, which is called nanostring, and they have a targeted thing for 48 targets in total, and this is totally ocular panel, which is 29 bacteria, 10 fungi, and it includes viruses as well. So things are really moving fast. Within 12 hours, you can get these results. and a clinical study that has been done in bacterial keratitis is already published. You can have a look at that. Now I come to the limitations of these. We are still learning in this area, technically demanding, and most difficult thing is it is centralized. It's not available to small labs. It's only in big places. You have to send samples and get the results. And a lot of clinical validation is required for these studies, for us to know how, when we can apply, what information is important for treatment, and what can be just ignored. So the softwares have to be really developed further to make them robust in results. Thank you so much for it.
Thank you, Dr. Savitri. Inviting Dr. Paras Mehta for her next talk on OSSN, the myriad clinical presentations. Dr. Paras. Any inputs from the chairpersons while Dr. Paras is putting her slides? Dr. A.K. Jain? Any inputs from the chairpersons while the slides are being put up?
We were just discussing that technology is improving and, advancing so much, and we're getting to the holy grail of becoming more efficient, more accurate, and improving the diagnostic accuracy. But at the same time, we have to balance it with the downside that things become more complicated and more expensive. So perhaps at some time it'll be like Uber. Dr. Prajna is saying that maybe there'll be some aggregating kind of a mechanism where a combination of things, it's not just one, it may be the clinical features plus the clinical appearance and then the microbiology inputs that can be, because otherwise it's a very vast country, and if you have high level resources available at one corner, it may not practically be feasible for everybody to access. But on the other hand, in the world stage, India is the best placed to take the lead and because it's not only about looking after everybody, it's also being cutting edge, and we can contribute a lot. So I really appreciate all the talks that we've heard so far.
Right, thank you, Dr. Radhika. Dr. Paras is here with her talk on OSSN.
Yeah, good morning, everyone. At the outset, I would like to thank AIOS and Dr. Somashila Murthy for giving me this opportunity. I'll be talking to you about OSSN. We all know that it is the most common malignancy of the ocular surface and comprises a spectrum of diseases ranging from dysplasia to invasive carcinoma. Intraepithelial carcinomas refer to superficial disease in the epithelium, only which is generally categorized as mild, moderate, or severe cases. But when the cancerous cells invade through the basement membrane, it is described as squamous cell carcinoma. So these are varied clinical presentations. Here you can see a diffuse flat lesion with feeder vessels. Here it is a gelatinous mass at the limbus extending onto the cornea, a diffuse but slightly elevated limbal lesion with feeder vessels, plus grayish flat lesion involving the cornea, which is known as pagetoid spread onto the cornea. Sometimes there may be a pigmentation with a plaque onto the surface. There could be an elevated mass with keratin and large feeder vessels. A limbal mass with corneal involvement and a lot of keratin onto the surface. Sometimes they present with a very huge area of involvement, late presentation, or there could be elevated mass with keratin and heavy feeder vessels. This case had a grayish lesion over the cornea with indistinctive features, and he had, on probing in detail, he had a history of probably a pterygium removal, which was not a pterygium, and it could have been an OSSN. So these are the cases who would require a map biopsy to identify the disease process. The lesions appear macroscopically as gelatinous, leukoplakic, papilliform, nodular, or diffuse, and they may be flat or elevated with feeder vessels, which may be present or it may be less distinct. Symptomatically, they may be associated with mild discomfort, pain, and irritation. The risk factors associated could be ultraviolet light, cigarette smoking, petroleum products, previous chronic conjunctival disease, chronic contact lens wear, even a Caucasian race is a risk factor, association with HIV and HPV infections, and xeroderma pigmentosa. The diagnosis is most often clinically, although definitive diagnosis is provided histopathologically with either incisional or an excisional biopsy, or other less invasive modalities such as impression cytology, exfoliative cytology, or even a fine needle biopsy, aspiration biopsy have been utilized. A confocal microscopy has shown promising results in the evaluation of ocular surface lesions. However, it requires contact with the eye, and it can, the section would be very small. Recently, anterior segment OCT or ultra high resolution OCT has been very helpful in allowing us to diagnose these cases. Though usually we traditionally rely on biopsy, the OCT demonstrated consistent features to allow the diagnosis prior to the excision of suspicious lesions. Being non-invasive, it provides a cross-sectional evaluation of the lesion and thus, in a way, an optical biopsy with a resolution between 2 and 5 micron without the need for direct contact with the eye. This is especially important because there is an increasing use of medical therapy. It helps us in diagnosing subclinical cases and at times incomplete therapy of those cases. OCT can potentially provide a non-invasive means of diagnosing, differentiating neoplastic epithelial lesions, particularly in the setting of a concomitant ocular surface disease. The corneal OSSN and corneal pannus can both present with clinical findings of an opalescent lesion and may have an overlapping finding on HROCT. Both the entities may show epithelial layer reflectivity, increased epithelial layer reflectivity on OCT. OSSN demonstrates an abrupt transition at a very vertical area, that almost 90 degrees of an angle, whereas pannus would appear as an angle transition around 45 degrees. Therefore, the angle of transition between normal and abnormal epithelium can be useful in distinguishing these features. As you can see here in a clinical photograph, where there is a superficial flat opalescent OSSN on the left side. On the right side, the OCT reveals thickened and hyperreflective epithelium with an abrupt transition point as shown by an arrow. As I said, it is very important that we can differentiate between subclinical cases. Here is a clinical case where there is a pterygium as well as OSSN associated with that, and you can differentiate the two with the help of HROCT, and even you can decide the endpoint of your treatment. So HROCT confirms normalized thin epithelium and subepithelial scarring which is consistent with only pterygium in the last slide, as you can see, last picture as you can see here on this OCT. The management algorithm for OSSN would include local immunotherapy, chemoreduction, surgical excision biopsy with other adjuvant therapy, resurgery or immunotherapy, plaque brachytherapy, enucleation, and orbital exenteration. The treatment has changed significantly over past 2 decades due to a greater understanding of the disease, improved diagnostic capabilities, and a shift towards the medical management of these tumors. We'll just look at some clinical scenarios. Here is a 60-year-old female presented with whitish lesion on the eye, redness, pain, and watering for 3 weeks. As you can see here in the clinical picture, there is a grayish pannus with at the limbus with vascularization. They are better delineated on red-free filter. And this is the clinical picture after 2 cycles of topical 0.04% MMC eye drops. You can see that lesion has almost resolved just on medical management, but you can reconfirm that on OCT whether there is any subclinical disease present or not. This is another case where this patient presented like this. Received, we gave 5FU 1% to this case. This is the second clinical picture after 1 month, after first cycle of 5FU. The third shows that almost the lesion has disappeared. But here also the OCT would help us in deciding the endpoint of your treatment. Surgical excision remains the most important treatment option in the management, especially in elderly patients with poor hand-to-eye coordination, or where there is a cost of long-term therapy and frequent follow-up is an issue. So extensive surgical, the downside is extensive surgical excision can result in limbal stem cell deficiency, scarring, and sometimes symblepharon formation. So before, the steps of surgical excision, one should be doing a thorough clinical examination to decide the extent of the tumor. One can use a rose Bengal dye for better delineation of the tumor, documentation, and both clinical and pathology. Photographic is very important. A clinical diagram and plan of surgeries also will help you on table. A wide excision beyond the clear margins, that is 4 millimeter on the conj side and 2 millimeter on the corneal side. One can do an alcohol epitheliectomy from the corneal side, cryotherapy to the conjunctival edges and base if that is needed. A histopathological examination of the biopsy specimen is must, and it should be labeled properly and spreaded properly to have a post-operative information. Sclerectomy, when there is an involvement of the sclera, can be performed. This is just a small 30-second video which just explains how we go about it. A 4 millimeter area is marked on the conjunctival side and 2 millimeter area on the corneal side, and you can do an alcohol epitheliectomy. You can literally roll the epithelium from the surface, and without actually touching the tumor, you can remove the tumor intact. And the same lesion can be spreaded over to a Whatman filter paper and labeled properly so that the pathologist can tell you the involvement of the edges, and the area is covered with the amniotic membrane at the end. This is another case where she was diagnosed to have an extensive pterygium, and on examination, if you do a dilated examination, one can even delineate the corneal lesion here very clearly. I'll just take a minute. So this particular patient needed chemoreduction, but it did not respond completely, so it was followed by an excision biopsy. So by doing a chemotherapy, you can reduce the size of the involvement, and then probably your surgical excision would be smaller. So this is the histopathological slide showing classical squamous cellness on histopath examination, and it turned out to be an infiltrative squamous neoplasia with keratin onto the surface. So if there are positive surgical margins, a re-excision is advised, or even a topical chemotherapy or immunomodulation can be tried. A paper from Bascom Palmer talks about treating these patients who are having positive margins or negative margins. They would like to use topical immunotherapy for 2 months. So that is their protocol. So advanced disease or multiple recurrences despite aggressive treatment may require sometimes extensive surgery in the form of enucleation or orbital exenteration. These patients need to be followed for 3 monthly for first year, 6 monthly for second and third year, and thereafter yearly. If the patient shows any signs of suspicious lesions, the management can be modified. This is another example where there is a diffuse involvement of the cornea and the limbal and the scleral region. You can see that very well onto the red-free filter pictures. She received 3 cycles of topical MMC 0.04% eye drops, 2 weeks on and 2 weeks off. Responded well initially, but later the lesion it had to be excised. So if we look at the first initial presentation, the area of involvement was much larger, but after chemoreduction it has become very small, and your surgical excision would be smaller in size. So this table just explains about various modalities of treatment which we can use. In our scenario, MMC and 5FU is easily available and cost effective, but one can also use interferon alpha 2B when it is not responding to MMC or 5FU. There are other therapies, photodynamic and plaque brachytherapy. The factors such as tarsal involvement, positive pathological margins, and higher pathological tumor grade, they have been implicated with higher recurrence. In refractory OSSN, chemotherapeutic agents can be used either sequentially or as a combined treatment. So just to end my talk, the take-home message here would be clinical and photographic documentation of NTA segment OCT is very important for these lesions. Careful management planning and optimal use of treatment options, including multimodal treatment, can result in minimal recurrence and probably avoiding complications. The compliance to the therapy and follow-up are the key to the success of this overall. So if availability and compliance is not the issue, it is best to use topical interferon in these cases. Thank you for your patient listening.
I invite Dr. Amit Gupta. He will be speaking on conjunctival lymphomas and other benign lesions.
Well, good morning. I would like to thank the AIOS for this opportunity. And I'll be talking about the basically the lymphoid-associated ocular surface lesions. And these mainly include basically the lymphoid hyperplasia, which may be a typical or atypical lymphoid hyperplasia or a lymphoma. And all of these are big mimics, and it's very difficult to sometimes distinguish one from the other. Important to understand the basic anatomy of the conjunctiva. We know the layers of the conjunctiva. It's also important to understand that the conjunctiva has the conjunctiva-associated lymphoid tissue in the substantia propria, and this can be a source of lymphoproliferative disease in the cornea. Along with this, we also have the eye-associated lymphoid tissue. Now, the tumors of the conjunctiva, they have been classified according to the layer from which they are arising. So we have the tumors arising from the surface epithelium, tumors of the melanocytic origin and adnexal structures, and then we come to the tumors of lymphocytic or hemopoietic origin and the tumors of soft tissue origin. For this talk, the focus is on the reactive lymphoid hyperplasia or the atypical lymphoid hyperplasia, and also lymphoma and other entities like leukemia or plasmacytoma, which might cause. So if you take a good look at these photographs, it's very difficult for us to reach a diagnosis, what it is. So for this, it's important for us to keep certain points in mind. These are specific regarding lymphoid tumors, but may be applicable to other masses as well. Usually these patients are asymptomatic. These masses are sharply demarcated, and if you see the salmon pink color, they say that on the slit lamp, due to the intense light, it may not be clear that salmon pink color. So the best thing is to examine the patient in daylight. They are insidious in nature, they are non-tender, non-ulcerated, and apparently they will lack the typical feeder vessels. And other features of that it's not really malignant would be a surface nodularity or follicularity, as is seen in this case, kind of multifocality and a minimum elevation of the lesions. So the photographs I was showing to you, number one was an amelanotic melanoma, the second was a conjunctival lymphoma, and third a benign reactive hyperplasia and a papilloma. Now, I can't overemphasize the role of the anti-segment OCT. It's such an easy investigation. It's an expensive tool to get, but it's very relevant to the corneal surgeons, and none situation more common, more applicable than this. Paras has shown some images of the OSSN, but in conjunctival lymphoma is a fairly typical kind of an appearance, that you will have a hyporeflective, homogeneous kind of a mass with dot-like reflectivity. And also there's a superior and inferior hyperreflective band, which is seen in these patients. This may also be present in benign reactive lymphoid hyperplasia, but classically in some cases, but it's a more disorganized kind of a structure which is there in benign reactive lymphoid hyperplasia. Conjunctival amyloidosis is something which may mimic these lesions, but again, this has a heterogeneous structures with irregular borders. So this is a classical appearance of a patient with, again, on one of those hyporeflective kind of a lesion. You can also see the subepithelial hyperreflective band in this patient. And this, on the other hand, if you see this is a patient of benign reactive lymphoid hyperplasia, you can see these hyperreflective areas actually corresponding to aggregations of the lymphocytes. This example just shows that it may be possible for benign reactive lymphoid hyperplasia to mimic the lymphoma. So, and again, the disorganized kind of an anti-segment OCT with some kind of a stippled kind of lesions which we see in amyloidosis. Now, if you look at ocular adnexal lymphomas, 20 to 30% of them will arise in the conjunctiva, and they are associated with systemic lymphoma. And usually the age group is more than 50 years. So when you have the age group of the patient is important, but it has been reported as young as 12 years of age. If you look at the epidemiology and the location, so 90% of these lymphomas, they arise from the B lymphocytes. And the term ocular adnexal lymphomas is commonly used, and they are unilateral in majority of cases, but they may be bilateral as well. So the etiology is very interesting in these patients. chronic inflammation can trigger the formation of these kind of lesions. And also the immune dysfunction disorders, Sjogren's syndrome, rheumatoid arthritis, SLE, and most interesting is infective organisms like Chlamydia psittaci and Chlamydia pneumoniae and hepatitis and Helicobacter pylori, herpes simplex virus and adenovirus. They have all been linked with the presence of these kind of lesions in the eye. Also some genetic factors like trisomy 3 and 18 predispose these patients. If you look at classification in these patients, so most of these, the most high grade ones, I told you that the major source is the B cell, non-Hodgkin lymphoma. So the most common out of them is the extranodal marginal zone lymphoma. This is important because once we take the biopsy and the report which comes, we should be able to prognosticate for the patient. Follicular lymphoma is also fairly common in these patients. So this diagram just shows actually that this marginal zone is what is responsible for the extranodal mantle cell. So how to stage it, Ann Arbor staging is not very applicable here since it's a localized disease. So we are going in for a TNM staging. So and important question is when to take a biopsy. Some of these lesions look so innocuous, and I really don't have a guideline for when to take a biopsy in these patients or not. But we should be probably more aggressive for caruncular or fornical lesions, which have more chances of being malignant or turning malignant later on. This patient had bilateral lesions and was very worried about them. So we did do an anterior segment OCT in this patient, which did show this very classical kind of a subepithelial kind of a band and with the kind of homogeneous kind of an appearance, not the classical like benign reactive lymphoid hyperplasia, but we did decide to go ahead and take a biopsy. But the staining characteristics showed that nothing more was required, and this was a patient of benign reactive lymphoid hyperplasia. This is a patient of Chinson's, and which I borrowed for this class, and very interesting patient, 55-year-old lady, and you can see the salmon pink color, classical color of this this lesion, the location of this lesion. You can't see a classical typical feeder vessel in this case. And once we did keep this differential diagnosis in mind of a lymphoma. Of course, an amelanoctic melanoma should be kept in mind, or an OSSN, or maybe one of these lesions. So if you look at the anterior segment OCT in these patients, you can see this presence of these lymphoid follicles and hyperreflective homogeneous subepithelial mass and hyperreflective normal epithelium. Immediately your antennas should be up that you want to be more aggressive while treating this kind of a patient. If you want to really check for some adhesion to the underlying structure, you can do the UBM and to see the if the angle is involved or the sclera is involved. Mobility tests should be done in these patients. Very important to have a good pathology team with you, because the pattern of staining that you will get ultimately is the pattern which will get you through this grid. And once you put the plus and the minuses together, you'll be able to reach the diagnosis as to what the patient is suffering from. The recommended investigations, we have to tailor them, but we do have to sometimes investigate in big detail, like radiograph, CT orbit, and endoscopy, blood counts, sedimentation rate, rheumatoid factor, serum protein immunoelectrophoresis, and maybe sometimes in biopsy, bone marrow biopsy, ANA, bone scan, liver spleen scan, and PET scan. In this case, if I go ahead...
So people have used hypoosmolar riboflavin to swell the cornea and then do cross-linking. Results have been found to be good. It was initially initiated by Farhad Hafeezi group, and the results have been found to be reasonably good, but definitely not as good as conventional cross-linking. And then people also thought, in order to prevent damage to endothelium, contact lens assisted CXL can be done. But then the issue is that, as we all know, that cross-linking works mostly in anterior two-thirds of cornea, and part of it will be covered by the contact lens, which will be discarded, will be thrown away. So the strength may not be that great. Number two, there is a post lens tear film, that is precorneal tear film, that impedes the penetration of UV rays, and that is also one of the reasons why the effect is not as good. Some people have tried transepithelial to prevent that part of the thickness of the epithelium, but again, it has not been found to be as effective. We at RP Center have done a study introducing intrastomal lenticule, which is a hyperopic lenticule. We initially started with the Visumax system. I don't have any financial interest, wherein we used to make a 7.8 millimeter pocket and introduce a lenticule of 7 millimeters. Now, this lenticule was created from a donor tissue, and it was ablated. 200 microns of tissue was taken, ablated. Central 4 millimeter was ablated for 75 microns in order to make it a hyperopic lenticule, so that we can have a thicker periphery to get us some arc shortening effect. But with the smaller diameter, the 7 millimeter lenticule, many times what happened that all these corneas are advanced keratoconus, and the peripheral thick part used to come over the cone, and that did not give us that great result. But then we moved on to the other system, and now we are creating a pocket of 9 millimeters and introducing a lenticule of 8.5 millimeters, and that is working better. So this is how it is done. It is introduced inside. Riboflavin is infused within the pocket once you have created it, and then it is introduced inside the pocket, and then corneal cross-linking is done. So it not only increases the tectonic strength, but it also has some arc shortening effect. I'll just show you a few. Not every case gives such a great result. Maybe we are just learning and we have to improve it. I've done a couple of such projects. Right now I've started doing one ICMR project on that. But there are some good results. But the biggest problem is that it has two interfaces. You are introducing a lenticule, there are two interfaces, one anterior, one posterior, and the risk of interface haze is very high. So that's why we do require use of topical steroid for a long period. Initially, we faced some interface hazes in these cases, and now with the use of topical steroid for a longer period, the interface haze has gone and we have clear corneas. I'll just show a couple of examples, like in this particular case. We have used 7.5 millimeter, 8.5 millimeter lenticule, and the initial K was 53 and 59, and post-op it improved to 52.0 and 53.7, so it worked quite well. Again, in another case, I'll show with a higher magnification. This is another case wherein the K1, K2 was 53.9 and 59.2. With this hyperopic lenticule and cross-linking, in the post-op period, it improved to 54.3 and 56. So it does show promise, definitely not in 100% of cases, so maybe we are learning how to improve further. And many times you get such nice, beautiful, bow tie pattern in the post-op period. Another important thing that has come up for thin corneas is adaptive fluence, which has been, again, it was published in AJO by, again, Farhad Afezi group. Now, this thing has further raised questions because they have used sub-400 protocol for cornea as thin as 214 microns. And they have said there are good results, but it has raised a lot of questions. Number one is that we have been knowing that we do require 400 microns for the endothelial protection, and now we are doing it at a thickness of 214 microns. Number two, if accelerated cross-linking, that is 30 milliwatt per centimeter square for 3 minutes, is not as effective, how can 3 milliwatt per centimeter square for 2 minutes in a cornea which is 214 microns will be as effective? So again, it has raised a lot of questions on this. Another thing that came up with the Thiosalar group was use of oxygen supplemented cross-linking, wherein they've used this oxygen mask. We created our own mask because this mask was 3,000 euros expensive, 3,000 euros, so it was very expensive for us. So we just used PPE kit, and it costed us only 400 rupees with everything. And we used 5 liters per minute of oxygen from an anesthesia machine. And with this mask, we could record, we could assess the periocular oxygen saturation as well with this anesthesia machine. And this has been published in the European Journal of Ophthalmology, this technique. So what we did, we made openings in the goggle, and through which we focus UV rays, we put riboflavin, and then we thought, this is the way how we, this is the Venflon that has been used to measure the oxygen saturation in the anesthesia machine, when we kept it at around 84-85%. We expected that, you know, since this free oxygen radical is essential for covalent bond, so more the oxygen, there will be more covalent bond. But the result was just marginally better than the control group wherein oxygen was not used. So it raised again a query that, you know, perhaps it's just not the oxygen that is directly related to the strength of to the effect of the cross-linking. And in order to prove that, we also wanted to know whether if we keep epithelium and use oxygen, and in another group we used hypoosmolar riboflavin, we found out that epi of hypoosmolar was slightly better than this oxygen supplemented epi-on cross-linking in borderline corneas. That was 400-410 microns. So in conclusion, we know that cross-linking is an established modality these days for arresting the progression of keratoconus. The issue is about thin corneas, a lot of queries raised because of some of the current studies as well. We have been working, hypoosmolar does have some effect, may not be as effective as conventional. We have been working on intrastromal lenticule, hyperopic lenticule with CXL, and let's hope with time we will become wiser in this subject as whether it is more effective and it works better or not. So thank you very much for your patient listening. And
Thank you, Dr. Rajesh. May I invite Dr. Radhika Tandon? She'll be speaking on pre-op ASOCT for surgical decision making in lamellar keratoplasty.
Have the mic on, please. Yeah, good morning, everybody. I'll try to rush through. I'm going to cover ASOCT and its role. Everybody in this audience is well experienced and knows that ASOCT is a wonderful tool. It can help you in diagnostic imaging and planning your surgeries. The only thing is I would say that you cannot take things in isolation. Just one instrument is not enough. So you have the clinical picture. For the morphology, we have the clinical picture, the optical and the ultrasound that can be used depending upon the case, and then the refractive maps, and then at the cellular level if you require the confocal scan. So you have to customize your investigations based on the clinical picture, and at the same time you have to teach and learn from the entire team, because sometimes you have a technician who's doing the investigation who may not be totally cognizant with the clinical implications. So let's not forget the benefit of the humble slit lamp photograph, and then as a cross section we have optical ASOCT. This is what I meant to say, that if you have a technician who doesn't know what the physical pathology is and is just taking the image and drawing a diagram, that could give a fallacious result. And the clinician, depending upon how busy they are, they cannot rely totally on the report that you get. So you have to put everything together. And it is not just a simple image, but you have to take particularly things like corneal dystrophies, etc. You have to have the full range of the standard clinical imaging. So ASOCT, as we know, is non-contact, non-invasive. It's an extremely useful tool. In cases where there may be a low visibility, you also combine it with UBM to see a better visualization of the anterior segment structures. And as far as the refractive, so it's not only a question of the depth of involvement, it's also what is doing to the surface of the cornea. So you have to also take the mapping of the cornea into consideration and involve both the placebo base as well as the Schemflug imaging to put everything together. I have no financial interest in any of the devices. So finally, I would say that at a cellular level, confocal microscopy, as we've already mentioned, that would again give you additional information. For example, what is the level of the involvement, what is the nature of the involvement, and the specular microscopy, let's not forget, sometimes you're doubtful. There are the cases which you're not very sure what it is, and you would also like to know what the endothelium is like. So here, coming to a few case studies, here we have a 30-year-old female who has a known case of Down syndrome. She had hand movements, and she was diagnosed a case of keratoconus with resolving high drops. And this is what we found on the ASOCT. So the high drops, the desmoids, there was a small pocket of desmoids which was still detached, and the cornea was still thick. And this is the mapping that was done, and we had planned the patient for a optical keratoplasty oblique talc. This is another patient who was 64 years old. He was diagnosed as a case of trachomatis sequelae with spheroidal degeneration, had a vision of 636 and 618. In such cases, it's good to know whether what is the nature of the cataract and what is the extent of the cataract, because whether you want to do a single-stage procedure or a two-stage procedure. This is the way the ASOCT showed a considerable amount of irregularity, and also you like to get a confirmation about the thinnest level. And then we planned a deep anterior lamellar keratoplasty. Here is the surgical video. The ASOCT preoperatively does help you to decide the depth that you would trephine if you're using a vacuum trephine as a starting point. So it helped me to decide the depth to go. This is a Moria version of a vacuum trephine. And then you do a lamellar dissection. And in the interest of time, I'll just advance it. Here I would say it is not only a question of 3D surgery, is kind of a fourth dimension where you're also getting the physical feel of the tissue. That can make a difference, because sometimes the tissues are much more hard and more rigid when you're doing the dissection. And then I had anticipated, because of the rigidity, I felt initially that a big bubble would not work. I still attempted it, but it was incomplete. And then I proceeded with a manual dissection to complete the case. This is another case, 81-year-old who had vision of finger counting, both eyes trachomatis keratopathy with spheroidal degeneration. So here's a little different from the previous case. So the diagnosis was similar, but the appearance is quite different. And the surgery here, again, we looked at the map, and then surgery was again to plan a deep anterior lamellar keratoplasty. This is an example of cases where you have perforations, where you have therapeutic keratoplasty, tectonic surgeries are planned. They can also help you to decide when to intervene and how to intervene, and then combined with the confocal microscopy that you may have. So with that, I'll stop. Thank you very much.
Thank you, Dr. Tandon, for that lucid presentation. So with that, we will be closing the session. I'll just have some closing remarks from the chairpersons and any questions from the audience. Last 2 minutes.
Thank you very much. That was actually a very comprehensive session. And I think the key thing what is coming out is there is so much to learn. And the dogma, like this 400 microns, 350 microns, and Rajesh presented that there have been studies even with 250 microns. And so I think we need to keep our mind flexible and be open to new for this session, and the moderators especially. I think this must be the first session in the AOS to start on time and to end on time. And I think we should really congratulate the moderators. Thank you very much.